was a housewife residing at Namakkal, presented with abdomen distension for past 2 months and abdominal pain for 20 days. Patient is apparently normal 2 months back. Then she noticed abdominal distension, which is generalized for past 2 months. Incidence in onset, it slowly progressed to attain the present size. Complaints of lower abdominal pain for 20 days, non-radiating, intermittent, dull aching, no aggravating factors, relieved by medications.
Yeah.
One minute, we lost.
You want to? Yeah.
No, we have lost the slide.
Okay. Yeah, take your time.
Is it visible, ma'am?
Yeah, it's visible. Yeah.
No history of early satiety, vomiting, or constipation. No history of hematomesis or melena. No history of bleeding, PV, or vaginal discharge. No history of hematuria, frequency or retention of urine. No history of fever, night sweats, loss of weight, loss of appetite. No history of cough, hemoptysis, jaundice, abdomen pain, or bony pain. No comorbid illness. No history of previous surgeries or medical illness in the past. Patient consumes mixed diet. She has normal bowel, bladder, and sleep pattern. And her menstrual history, she attained menarche at the age of 13. She was having regular menstrual cycles, 3 by 30 cycles, married at 21. She's a P2L2, first childbirth at 22 years. She adequately breastfed the kids for around more than 1 year. She attained menopause at 47 years. No history of OCP usage or hormone replacement therapy usage. No history of breast, ovarian, or colorectal cancers in the family.
Yeah. Okay.
Shall I summarize the history?
Yeah, please summarize your history. Yeah.
My patient is a 57-year-old postmenopausal lady with abdominal distension for 2 months and abdomen pain for 20 days with no other contributory history, ma'am.
Okay, fine. Go to, I will not discuss the history again this time because that was already discussed. Only thing is, yeah, bony pain you can avoid in ovary. If you feel it is ovary, bony pain you can avoid. Okay. That's the only feedback. And yeah, okay. I think we've discussed history in detail last time. We can go to examination.
Systemic examination, shall I proceed, ma'am?
Yes, please.
Patient is conscious, cooperative, well-oriented to time, place, and person. She is moderately built and nourished. ECOG 1 with stable white eyes, no pallor, ictus, cyanosis, clubbing, or generalized lymphadenopathy. No axillary, supraclavicular, or inguinal nodes. Skull, spine, and bone normal. Bilateral breast normal. Systemic examination normal. I would like to proceed with abdominal examination. On inspection, abdomen is distended. Distension is generalized. Umbilical central and flustered surface, and flanks are full. Respective quadrants move symmetrically with respiration. No scars, sinuses, abdominal wall edema, or dilated veins. No renal angle fullness, and hernial orifice is free. External genitalia normal. Palpation, diffuse abdominal distension present. On deep palpation, a non-tender mass of approximate size 10 by 10 centimeter palpable in the lower abdomen, firm in consistency, lower border not felt. I am not able to measure the extent of the margins and extent of the lesion due to ascites. On percussion, the abdomen is dull over the flanks and resonant in the periumbilical region. There is shifting dullness on changing the position, but there is no fluid thrill. Auscultation, normal bowel sounds here. Pervaginal, speculum, and rectal examination. External genitalia was healthy, cervix and vagina normal. No pouch of Douglas deposit was felt. Rectal mucosa was normal. On bimanual palpation, 10 by 10 centimeter mass, bimanually palpable in the right adnexa. Uterus not separately palpable. No transmitted movement of cervix onto the abdominal mass. On summarizing, my patient is a 57-year postmenopausal lady with complaints of 2 months progressive abdominal distension with 20-day history of lower abdominal pain with no other significant contributory history. Examination revealed moderate ascites with bimanually palpable mass of 10 by 10 centimeter in the lower abdomen.
Yeah. Can you go back to your examination, the first slide? Okay. So, because for paucity of time, please make sure that you know what the ECOG scores are. What does ECOG 1 mean? What does ECOG 2 mean? Because you can be asked
Yes, ma'am.
by some examiner. There are some examiners who like to go into the basics.
Yes,
So you should know, you should not fumble at this. Okay.
yes,
Uh, Again, cyanosis clubbing you may avoid in ovary. Cyanosis and clubbing is not something, although it is part of your natural history, which you used to take as MBBS students. Cyanosis and clubbing can be avoided because there is hardly any case I have seen up till now where we have seen cyanosis or clubbing. Okay. Yeah, rest is okay. Next page. Yeah. So, before you begin with examination, you should always, again, some basics.
yes.
Please tell that you ask the patient to void urine, and you are examining the patient from right side. And when you are a male, please make sure that you say that with a female attendant. Okay. Again, there are some examiners who are a little particular about it.
Yes, ma'am.
Yeah, this is okay. External genitalia, you can just put at the end. Otherwise, this is okay. All right, we've discussed this in the last class. Yeah.
Ma'am, I
Yeah.
have one question, ma'am.
Yeah. Can we take
Depend.
questions in the end? You can ask, but I would prefer because it's a very lengthy topic. We can discuss all questions in the end. But please go ahead, ask your question now.
No, ma'am, basic. If you want to give a differential diagnosis, present on only history, ma'am. This says I have only abdominal distension and pain.
Yeah, we'll
So,
discuss. We'll come to the
okay.
differential. We'll come to the differential. Yeah. So, okay, now when you do a PSPVR examination, so instead of writing write adnexa, we don't say adnexa in the examination. Normally, when we feel for the adnexal mass, we feel it through the fornix. Okay.
Right.
So you can say that a 10 by 10 centimeter bimanually palpable mass in the right fornix. Uterus was not palpable separately. When you are saying that uterus was not palpable separately, you can avoid no transmitted movement of cervix onto the abdominal mass because you, in any case, you cannot distinguish when there is a big size mass or the mass is adherent to the uterus.
Yes, ma'am.
Okay. Yeah.
Actually, that mass was palatable, ma'am. Internal palatability was there. Due to ascites or not, I don't know, ma'am. But
No, that's okay. That is quite okay. In ascites, many times we cannot find the mass separate from the uterus. You are right in your examination. Okay, there's nothing wrong. Just don't use the word adnexa. We normally say fornix. Okay.
yes,
Okay. Now, based on your history, what is your clinical suspicion and
because
why?
those abdominal distension along with the abdominal pain, ma'am. Short duration, the distension was progressing. So likely it should be some ascites with as the pain is pointing towards lower abdomen. It is likely a abdominal pathology, likely a pelvic pathology. It could
Right.
be considering the age, it could be tuberculous abdomen, or it could be any pelvic pathology with ascites, likely ovarian malignancy.
Okay. So, I'm sorry, I missed out on the age. She was how old?
57 postmenopausal for 10 years.
Yeah, so I think you have to keep the differential of TB also, but you have to also say why you are supporting it. So she had abdominal distension for 2 months, and she did not have any particular aggravating factors and no relevant significant history. So the first differential is malignant ascites due to probably of gynecological origin, likely ovary as first differential. Which other gynecological malignancy can present with ascites commonly?
Commonly, even cervix or endometrium can also present.
Cervix, generally ascites on clinical presentation is rare because most of the time the spread of cervix is loco-regional. So, ascites presenting in CA cervix, it does happen, but the commoner presentation is locally advanced. Endometrium, which type of histologies are more likely to have ascites?
When it is associated with peritoneal disease, clear cell or
Yeah, uterine papillary serous cancers. Okay, so uterine papillary serous, the type 2 histology can also present with ascites. Okay, and a similar differential after examination, would you like to add anything to your differential, or you would like to proceed with these two only?
I would go more in favor of malignant ovarian pathology, ma'am, as my first differential diagnosis.
Right. What would be your second differential?
As the mass is palpable, it could be and in the right head neck side could be appendiceal mass with peritoneous mucinous.
Yeah. So first you should say gynecological causes. First is yes, ovary is one. Second is because uterus is not felt separately. It could possibly be an advanced case of endometrial CA, like uterine papillary serous. It could also be non-gynecological origin. Okay. So with differentials of appendicular mass and abdominopelvic cox. Yeah, fine. Okay. So yeah, uh, you can go to your next slide.
Yes, ma'am.
Yeah. So make sure that you're adding some differentials. Okay. So this is it. I think 3 or 4 differentials should be enough. Fine. Okay. So how will you investigate this patient?
After doing basic blood workup along with tumor markers, I would like to do CCT abdomen and pelvis.
Okay. So do you only want to do CT abdomen and pelvis, or would you include thorax as well?
Along with thorax.
Yeah. So this is an advanced case. So it's not an early case. In advanced case where you are already suspecting ascites clinically, you should go for a complete evaluation of CT thorax, abdomen, and pelvis. So, so what is the modality of choice in advanced CA ovary? Which is the diagnostic radiological modality of choice?
Contrast in CT scan of abdomen and pelvis system.
Correct. So does PET CT add to your diagnosis? Would you like to do PET CT in this patient?
No, ma'am. PET CT doesn't done much to the evaluation, initial evaluation.
Why?
Peritoneal metastasis is less likely to be visualized in PET CT.
Yes.
Which is the commonest presentation of advanced ovarian cancer. And apart from that, ovary is less likely to present with other visceral metastases. So,
yes, more importantly, a good thin slice CT gives you all the adequate information which you need. Many times in PET CT, the CT images which we do are thicker, the CT slices are thicker, so you may actually miss out on some disease. Is there any other modality which is maybe not currently the investigation of choice, but has been used in clinical trials for assessment of disease in a case of advanced CA ovary?
MRI can be.
Yeah, which MRI?
MRI of pelvis and abdomen, both for peritoneal disease.
Contrast enhanced MRI with diffusion weighted imaging. So there are a lot of trials which have shown that a contrast enhanced MRI with diffusion weighted imaging is more sensitive in picking up peritoneal disease and especially serosal disease, which is important in deciding the management of the patients. Reason being that it can pick up disease which is less than 5 millimeter, also, provided it is read by an experienced radiologist, and it is effective in picking up serosal and peritoneal disease much better, sometimes even scoring over CT scans. But right now, it is not being used routinely. It is being basically part of clinical trials. As of now, the treatment of the investigative modality of choice is CT thorax, abdomen, and pelvis. Okay. Yeah. What else will you do besides an imaging?
Yes, ma'am. Besides imaging, I would like to do tumor markers and also ascitic fluid for cytology.
Okay.
Cytology and cell block.
Okay. So before you go ahead with ascitic fluid cytology and cell block, there is something which you need to do. What is it that you need to do before we go ahead with cytologies and biopsies?
Yes, ma'am. We need to do blood workup complete hemogram, and renal function test, coagulation
That's
profile.
okay. You've already said that you have, you have done the routine test. That's fine. So, it's a case of advanced CA ovary. Okay. So now, when you have done a CT thorax, abdomen, and pelvis, there are some patients where you would like to consider them for upfront surgery. Number one. Number two, there are other patients you would like to consider for neoadjuvant chemotherapy. Okay. So on when you do a CT scan, you look for the disease distribution, the disease assessment, and whether you are likely to achieve an optimal cytoreduction based on these CT findings. Okay. If you are likely to achieve an optimal cytoreduction, of course, it depends on the institutional policy. Most of the times, we go ahead with primary surgery first, primary cytoreduction first, and remove the mass and send it for intra-op frozen section analysis. Okay. In these cases, we normally don't do a cytic fluid cytology. So first you have to see the disease distribution on CT scan and see whether the disease is upfront operable or not operable. Where you feel it is less likely to be operable and you are considering neoadjuvant chemotherapy, then you will go ahead with cytology and a biopsy. Okay. There are some institutes which would like to go ahead with biopsy either which ways, even before a primary cytoreduction. But in most of the cases, we go for an intra frozen section because the history is typical. CA 125 is quite raised. She is a 57-year-old lady. The only role of doing a biopsy before doing a primary cytoreduction is basically to rule out low grade serous, okay, because those are the ones which don't respond to chemotherapy. So for ruling out low grade disease, A, it is not that common. B, the CA 125 is quite raised. And C, first show your CT findings.
This contrast enhanced CT of chest and abdomen, chest saline procedure.
Yeah, if you have something relevant in chest, you can show.
No,
Otherwise, you can. Otherwise, yeah.
Sure. Yeah.
இது பண்ண பிரச்சனை இல்லை.
Is it visible, ma'am?
Yeah, it's visible.
There is very minimal right side pleural effusion, and there is ascites along with likely peritoneal deposits in the right diaphragm, which
Yes.
shows irregularity and
Very clearly visible. Yes.
little scalloping, and there is no liver nodules. You can see there is some momental thickening here, and also ascites, and here there is momental nodules. There is also abdominal wall nodules.
Okay.
Here, and there is some momental caking is there.
Yeah, sure.
Nice. Abdominal wall nodule, there is a large nodule here, and this is the primary. It's a solid cystic mass with solid component here, and the right ovary, it seems like the left ovarian mass, and the right ovary is replaced by solid mass, but there is nothing in the peritoneal POD, ma'am.
Okay.
There was no nodes, ma'am. No hydroelectronecrosis.
Right.
No parietic nodes and pelvic nodes, ma'am.
Okay. Yeah. And you mentioned she's ECOG 1. Okay. Yes, so based on the CT findings, we basically have to see the general condition of the patient, number one. Number two, we have to see the CT scan findings as to the disease is upfront operable or not. I'm sorry, my dogs are barking. Just sorry. Just give me a second.
Yes, ma'am. Yes, ma'am.
To do all of this.
No idea.
Okay. So, ideally, you should do a genetic testing first with a complete gene panel of NGS. Okay. If a patient is found to have a gene mutation, if a patient has genetic mutation, automatically the tumor tissue will also show mutation. So, such patients may not be subject to the HRD testing. HRD testing is actually expensive. It can, in any good center, it can, cost anywhere between 80,000 to 1 lakh. So, uh, ideally you should go for a genetic testing first. If the genetic testing is positive, then no need to go for HRD. If it is negative, then go for an HRD so that you can decide which patient should receive PARP inhibitors and where it can be avoided. Where there is no HRD, if the HRD deficiency is not present, okay, patient does not have a germline mutation either, which is about 50% of the population. In those patients, we don't give PARP inhibitors, but we do give what?
Bevacizumab.
Correct. What is bevacizumab?
Bevacizumab is a VEGF inhibitor.
Yeah. So,
Angiogenesis inhibitor.
And what evidence do we have to its clinical utility? When should we give bevacizumab ideally?
In the recurrent setting.
In suboptimal cytoreduction also we can give.
No. So yeah. So before you jump to recurrent setting, that's right. In patients who have a suboptimal, the ideal candidates for bevacizumab is an anti-angiogenesis inhibitor, which is given in along with chemotherapy, both in adjuvant as well as in maintenance settings. Okay. Now, its maximum usage or maximum clinical efficacy is in patients who have undergone a suboptimal cytoreduction or had stage 4 disease. Okay. Can you use bevacizumab in neoadjuvant setting also?
It increases the complication of surgery.
We can
use some, but last cycle we have to avoid because it increases the complications of surgery like bleeding and fistula formation and impacts wound healing, ma'am.
Yeah, so there is no, as of now, there is no level 1 evidence for the use of neoadjuvant bevacizumab. It is being used in some centers. However, there are certain side effects, namely wound complications, okay, wound infections, wound dehiscence. Secondly, increased rates of anastomotic leaks, okay. And third, of course, it can cause bowel perforation also in some cases. It can cause pulmonary hypertension, proteinuria, okay. All these are complications of bevacizumab. And if we have to use bevacizumab in a neoadjuvant chemotherapy, a neoadjuvant setting, normally, it is used in patients who have massive ascites and pleural effusion if it is not responding to first line chemotherapy. And we have to keep at least a 6 weeks gap between the last dose of bevacizumab and surgery. So, if it has been given in a neoadjuvant setting in the just the last cycle before you take the patient up for interval cytoreduction, in the last cycle we avoid bevacizumab so that that 6 weeks gap is maintained. If you have done a primary cytoreduction and you are starting adjuvant chemotherapy, then in adjuvant chemotherapy, the first adjuvant chemotherapy cycle should be without bevacizumab. You should start the bevacizumab from the second adjuvant setting, and then it is given in maintenance settings also. So, in patients who are BRCA wild type and non-HRD deficient, bevacizumab can be used with paclitaxel carboplatin, both with the 6 cycles of adjuvant chemotherapy as well as in the maintenance setting. So, do we have any evidence to utility of bevacizumab in advanced C ovary?
Yes, ma'am. In recurrent setting, we have evidence for Oceans and Arulia.
No, have it in upfront setting also.
GOG 252 or 252, ma'am.
Icon 7. GOG 252, ma'am.
GOG 252 was something else. Bevacizumab was basically GOG 218 and Icon 7. Okay, these were the two trials. GOG 218 was the American trial, Icon 7 was the European trial. So these trials basically reported some improvement in PFS to the amount of 4 to 6 months. However, no significant improvement in overall survival. Although there are, now when we study the long-term data, there are some indications of slightly improved overall survival also. In recurrent setting, the use of bevacizumab in platinum-sensitive disease was in Aurelia study, and in platinum-resistant disease was in
Oceans.
Sorry, Oceans was platinum sensitive and Aurelia was platinum resistant. Yeah. Okay, correct. All right. So GOG 252, now that you have mentioned GOG 252, I, as a gynae oncologist, I cannot remember the GOG trials. I don't know how you remember 252. Now that you've put your foot in your mouth, what was G252?
That is for intraperitoneal chemotherapy. From GOG 172 and 252.
No, I'm talking about 252. He said 252. What was 252? So GOG 252 basically had compared, weekly chemotherapy with, 3 weekly with use of bevacizumab. So it found that there was no improvement in, any survival with the use of weekly chemotherapy, but that could possibly be because of use of bevacizumab. Okay, this is not a very important trial. I mean, for you guys, this is more of medical oncology, but yeah, if you utter a name, you should know what it is. Okay. So, yeah, all right. So now you talked something about intraperitoneal chemotherapy. So, okay. So what was intraperitoneal chemotherapy? What was the evidence which we had, and why are we not using it so much now?
GOG trials, there were 172 and one more trial, ma'am.
That's okay. You needn't remember the names. Okay. Yeah. So the most important one was the GOG 172 trial, which was by Armstrong. There were other trials also before that, which were by Alberts and Markman, but Armstrong was the most important trial. So Armstrong trial basically used intraperitoneal chemotherapy. Intraperitoneal chemotherapy was given both with cisplatin and again with paclitaxel, along with IV paclitaxel, and it found a 5 to 6 month improvement in PFS, but more importantly, a 17-month improvement in overall survival. So you can just remember a significant improvement in overall survival, and that actually led to an NCI alert in 2006, where they said that intraperitoneal chemotherapy should be given to all patients. So all the GOG trials mostly are based on primary cytoreduction. Remember that, because neoadjuvant chemotherapy is not followed that much in the US. So most of the GOG trials will be after primary cytoreduction. So they found that there was a marked improvement in overall survival. However, the caveat was that only 40% of the patients were able to complete intraperitoneal chemotherapy. Reason being that there were some catheter-related complications, catheter blockage, leakage, extravasation of fluid, and there were severe electrolyte abnormalities. So as a result, because only 40% of the patients were actually able to complete their chemotherapy, the intended 6 cycles, it fell out of vogue. Okay. So what came in vogue now that the intraperitoneal chemotherapy was gone?
Hypothermic intraperitoneal.
Yeah. So briefly, what is basically the treating principle of HIPEC?
It is a single stage modality after cytoreduction. If we achieve complete cytoreduction, we can give heated chemotherapy, ma'am.
Yeah. So basically, this is there are certain drugs which act intraperitoneally. Okay. For example, cisplatin, including paclitaxel, even carboplatin. These drugs are when they are heated, okay, the action of heat over and above their intraperitoneal action increases. There is production of heat shock proteins, there is cell apoptosis. So that is why these cells are able to act on the tumor microemboli after achieving primary cytoreduction. But the treatise is that the patient should have undergone an optimal cytoreduction, ideally a CC0, but at least a CC1, okay, in advanced epithelial ovarian cancer. Pseudomyxoma peritoni is the only this thing where, you can get away with even a suboptimal cytoreduction, but in advance, it should be at least a CC0 or a CC1, number one. And number two is that basically it allows it allows giving us chemotherapy through intraperitoneal route at a time where adhesions have not formed. So because adhesions have not formed, the drug is able to uniformly circulate in all compartments of the abdomen and act better, unlike intraperitoneal chemotherapy, which is not a one-time thing. It is given over 6 cycles, number one. And secondly, adhesions keep forming. So sometimes it may not be able to deliver optimal drug delivery in all sites. Okay. So what is the evidence for use of HIPEC in advanced CA ovary?
OV HIPEC and Korean KOV HIPEC trial.
Yeah, can you just briefly tell me what were these trials and what did they show?
OV HIPEC is by Vandrel et al. They included stage 3 patients. With cisplatin, they use for 90 minutes, 100 mg per meter square, and they show improved benefit, ma'am. Whereas in the Korean limb et al. Trial, they included stage 4 also and found that stage 4 patient did not have any benefit. Only for stage 3 patients have benefit from HIPEC.
Correct. So well, that's good. So the OV HIPEC trial was, like she correctly mentioned, it was for advanced CA ovary. Okay, advanced CA ovary stage 3C, which was not amenable to upfront primary cytoreduction. Therefore, these patients received 3 cycles of chemotherapy, and when they were taken up for interval cytoreduction, they were randomized into receiving HIPEC versus no HIPEC. Okay. So normally the most common drug which we use in ovarian cancer for HIPEC is
cisplatin.
Correct. There are various regimes being used for cisplatin. There are some regimes which have used 75 milligram per meter square for 60 minutes. There are 80-minute regimes also. Vandrel trial used 100 milligram per meter square, but the caveat was that the entire dose was not given upfront. In the first half an hour, 50% of the dose was given. In the next half an hour, 25% of the dose was given. And the last half an hour, the remaining 25% was given. Okay. So, and it also, because it used a higher dose, it also used a nephroprotective agent. What was the name of this nephroprotective agent?
Sodium thiosulfate.
Yeah, sodium thiosulfate. So, is sodium thiosulfate available in India?
Don't know, ma'am.
Yes, it is now available in India. Okay. So this is the trial which has actually shown improvement with 100 milligram per meter square. You don't have to deliver it together. And we should always use by pre-administration of sodium thiosulfate. I will not go into the technical details of HIPEC because that's a very long topic. Okay. So like you rightly said, there was an improvement in overall survival. Overall survival was improved by almost 12 to 13 months. And this is the level 1 evidence which we have for the use of HIPEC in interval setting. And this has been accepted by the NCCN guidelines as well. Okay. Now, do we have any evidence? The Korean trial included patients who basically underwent both primary and interval cytoreduction. It was a mixed bag, and also who were stage 3 and stage 4. So overall, if you look, the overall results did not show any improvement in survival. But in a subset analysis, patients who were stage 3 and underwent neoadjuvant chemotherapy, there was an improvement in survival. Do we have any, should you use HIPEC in primary cytoreduction?
OV HIPEC 2 is ongoing trial.
Yeah, so it is ongoing. So what is your answer? Should you use or should you not use?
There is no high-level evidence.
So as of now, we don't have any level 1 evidence. So in primary cytoreduction, HIPEC should not be used outside the setting of a clinical trial as of now, till we achieve more evidence. Should you use HIPEC in a recurrent setting?
Yes, ma'am. We can use, ma'am.
Okay, which type of recurrence?
Platinum sensitive recurrence with increased DFI. More than ego criteria, that fits into ego criteria.
So don't add unnecessarily. You were right before. So learn when to stop. Okay, AGO criteria was used only in the desktop trial. SOC did not use it. The GOG also trial did not use it. Okay, and in most of the cases, we are not using these specific criteria. We are going by whether the disease is upfront resectable or not, based on the patient's general performance status and based on the imaging findings. Okay, so uh, earlier in recurrent setting, we had some evidence coming from MSKCC, Zavonich et al. They basically they used carboplatin rather than cisplatin, and they found that there was no improvement in PFS and OS. There was an old trial by Spiliotis which showed improvement in survival, but that was a poorly conducted trial. It had its many drawbacks. Like patient selection criteria, post-operative complications, all this was not mentioned. So recently, we have had two trials which have reported the use of HIPEC over and above secondary cytoreduction. So secondary cytoreduction is in any case advisable for patients who have a platinum-sensitive relapse. Okay, so a disease-free interval should be ideally 1 year, but at least more than 6 months. Okay, the disease should be upfront operable. Okay, so the recent studies have been the CHIPOR study and the horseback trial. Okay, so these are two recently published trials. One is CHIPOR, CHIPOR. Okay, in bold capitals. It is a multi-center French study. So here, basically, for patients who had a platinum-sensitive relapse, that is, disease-free interval was more than 6 months, these patients first received 6 cycles of neoadjuvant chemotherapy, and after getting 6 cycles of neoadjuvant chemotherapy, they underwent secondary cytoreduction and were randomized into HIPEC versus no HIPEC. Okay, and patients who received HIPEC actually received 75 milligram per meter square over 60 minutes. They used this older protocol. Okay, and they found that there was a significant improvement in overall survival. Okay, the other trial which we have is the horse trial. Horse trial basically inducted patients of platinum sensitive ovarian relapse, but these patients did not receive neoadjuvant chemotherapy. They were upfront taken up for secondary cytoreduction and again randomized into uh, this was by Fagoti group into HIPEC versus no HIPEC. So this trial did not find any improvement in PFS. Here in CHIPOR trial, the primary outcome was overall survival, whereas in horse trial, the primary outcome was PFS. So they did not find any improvement in PFS, but they did find an improvement in recurrence free, in overall survival after developing recurrence. That is post recurrence survival. We call it PRS, post recurrence survival. So there was a notable improvement in post recurrence survival with addition of HIPEC in the post trial. So as of now, we don't have any guidelines guiding us to whether it can be used in secondary cytoreduction or not. But we do have the results of CHIPOR study, and we have a possible positive effect from horse trial because at least the post recurrent survival was notably improved in the HIPEC group. Okay. Now, what is Kellim score? KELIM. Come on, this was discussed in the Namakal conference. You should be knowing this.
In CHIPOR study, they use it for the sensitivity of cisplatin, madam.
Yeah, not just CHIPOR study. It has been used in many trials. What is it?
How good they are sensitive? The patient is responding to chemo.
So basically, CA 125, we need three measurements of this. Is basically Kellim score is used in upfront setting. It is not used in recurrent setting. Okay, it is not validated for recurrent setting as of now. When we give new adjuvant chemotherapy, we have to predict which patients are likely to undergo a good response. Okay, so this is assessed through a new score. This is known as Kellim score. That is basically stands for CA 125 elimination rate constant. Okay, so we record three findings of CA 125 over a period of 100 days when the patient is receiving chemotherapy. Okay, and we see the decline in CA 125. If the score is 1 or more, okay, that means there has been a significant decline. That's a favorable score. If the score is less than 1, that means it's a less favorable score. Okay, so Kellim score, if it is more than 1, more than equal to 1, that means A, the patient is more likely to respond to neoadjuvant chemotherapy. Number 2, it is more amenable to optimal cytoreduction, okay, in the interval setting. And third, patients who have a higher Kelm score have a better PFS and OS as compared to those who have a lower score. Okay, so this is basically what the Kelm score is. You can get a short note. It's quite in vogue these days, and there are many trials which are ongoing regarding, all of this regarding the Kelm score. Okay, just give me 1 second. I just want to basically, it's already 9:40. Oh my God. Okay. You guys have you are, do you want me to stop or is it okay?
No, ma'am. No, ma'am.
Okay, yeah. Okay, no. All right. Just let me go through some of my notes to ask you some questions if I have missed any. Just give me 2 minutes. In the meantime, you can put some questions on the Q&A group and you can, maybe just read out if in case there are any questions.
Ma'am, in case of there is a stage 4 disease, for example, cervical node or intraparenchymal liver mets, and they vanish off after 2 scenarios. So one, it is still there, and abdomen has gone. Other scenario, it is totally gone. So shall we intention will be curative or palliative?
No. So sorry. If it is a stage 4 disease, okay, the extra abdominal disease is more likely to get resolved with chemotherapy. There is hardly a scenario where you will find that the abdomen is completely resolved and the chest is not resolved. Okay, so normally if there is a very good response in abdomen, okay, in that case, generally the extra abdominal disease resolves as well. If, however, now the answer to your question, if there is an incomplete response, okay, after neoadjuvant chemotherapy, then we have to see how much the response is there. Okay. Secondly, we have to go back on our biopsies. Okay, whether the biopsy was high grade serous, there is no low grade element, and then if all this is confirmed, we may either, if the response has been partial, then after 3 cycles, if the response has been partial and the disease is not amenable to complete cytoreduction, you can go ahead and give 6 cycles of chemotherapy if there has been a partial response, and then reassess after 6 cycles. In that case, if after 6 cycles the disease is operable, we will operate, and we can give one or two more adjuvant chemotherapy. So normally the adjuvant chemotherapy cycles are 6 to 8. Okay, when there is a good response after 3 cycles, then in those cases we operate after 3 cycles and give 3. If there has been a partial response after 3 cycles and disease is not amenable to to complete cytoreduction after 3, but there has been a partial response, then we can give 6 and operate after 6. If there has been a complete, there has been no response or there has been disease progression, it is these cases where you give second line chemotherapy. Okay. Now, this is one question which I should have asked.
It means that our intention should be always curative, madam.
Initially, 75% of advanced ovarian cancers will be diagnosed in stage 3 and stage 4. As long as patient's general condition is good and she is able to tolerate systemic chemotherapy, initially upfront, the treatment is always curative. We never say that if it is a stage 4 disease, intraparenchymal disease, that the intention is palliative. We never write palliative chemotherapy, even in stage 4. If patient's general condition is good and she is able to tolerate systemic chemotherapy, even in stage 4B disease, okay, the treatment is curative. It is only when the disease A is not responding, B, the patient has developed severe toxicities and is no longer able to withstand chemotherapy, okay, or it is a platinum refractory disease, which, for which you don't have any second line or third line management, or it is progressive disease, then we come to palliative. Then our intent becomes palliative. But upfront, it is always curative, as long as patient's GC is okay, at least for systemic chemotherapy. Her GC may not be good enough for primary cytoreduction, but it should be at least good enough for receiving neoadjuvant chemotherapy. Okay.
Ma'am, after complete response, do we have to address this area or we can just monitor them, for example?
So
cervical node or parenchymal met?
No, yeah. So in stage 3 disease, ideally in stage 3 disease, after you take the patient after 3 cycles of chemotherapy in an interval setting, the aim should be to resect all the disease which was involved prior to initiation of chemotherapy. Okay. In stage 4 disease, where the disease was extra abdominal to begin with and has now resolved with neoadjuvant chemotherapy, 3 cycles. Once you take these patients up for cytoreduction, we do cytoreduction only in the abdominal compartment. There are some clinical trials where they have done VATS and have even removed the involved pleura. But as of now, in the standard guidelines, the cytoreduction is generally limited to the abdominal compartment. Maybe you can remove some inguinal nodes or cardiophrenic nodes, but you don't go about removing mediastinal nodes or lung mets or, for that matter. So normally in stage 4, we limit our resections to removal of residual disease, okay, because we are operating in the abdominal compartment.
Madam, one general other question, madam.
Yeah.
In case of madam, there is a young female desiring for fertility, and it is stage 1 and 2, and there is suspicious it is borderline or not. How will you, in clinical practice, you decide to go for fertility preservation, or you want to, whether frozen does really help, or if there is no frozen section?
Okay, that's a very good question, and it's a very practical question. And I'm very good it has come from a surgical oncologist. So, where, in young patients, you have suspicion of borderline C ovary. Okay. Now, borderline ovarian, in even the best of institutes, the accuracy of frozen section is about 80 to 85%. Okay. In up to 15 to 20% of the cases, the disease may be upstaged in upfront setting. In final histopathology. Now, in young patients where there is a borderline disease, borderline ovarian cancer, or which may or may not be an invasive cancer, if we have to if there is a young patient, ideally in those cases you should wait for the final report to come, even at the cost of doing a second surgery. Okay, because these are patients where you should not just rely on frozen section, because removing the other ovary and uterus is an irreversible step. You cannot reverse it. So in these cases, wherever there is doubt, it is better to remove the involved adnexa, do a staging, do a fertility sparing surgery in the first setting, then wait for the final histopathology, because in final histopathology, they'll be studying all the sections. You may miss invasive disease in some sections on frozen section, but when you do a final histology, you are doing, you're examining all the slides. So you should tell the patient in such settings that, because you are not married or you don't have a family, if the disease is not widespread in preoperative imaging, it is indicative of early disease only. You have to tell that initially we will remove the mass, we'll do a staging, okay, but she may require a second surgery if the final histopathology is suggestive of a higher grade cancer. Okay, so in patients who have not completed family, always counsel the patient for second surgery if it is required, and secondly, to wait for the final histopathology, not to take drastic irreversible steps just on the basis of frozen section. So in these cases, normally in our clinical practice, if we do find such patients, we remove the disease, we remove the involved adnexa plus minus the pelvic peritoneum, do a staging, preserve the uterus and the contralateral adnexa. In case the final report is suggestive of a higher grade cancer, then we operate in a second setting, and we inform this preoperatively to the patient. And secondly, it's always a good practice to advise these patients oocyte preservation before you take them up for surgery, because nowadays we have short induction protocols wherein they can pick up ova in as less as in just about 2 to 3 weeks time. So wherever possible, the patient should undergo oocyte preservation. If a patient has a partner, then the success rates of embryo cryopreservation are better than oocyte preservation. Okay, the implantation rates of embryo are more than that of unfertilized ova.
Any change in approach in sex cord and germ cell? Same scenario?
Sex cord stromal cells, normally we can go for fertility sparing surgery. Secondly, they don't require lymph node dissection because most of them, less than 3% of them have a lymph node involvement. So these are actually patients which you can actually, if they are early disease, you can go for fertility sparing.
Thank you, ma'am. Thank you.
Okay, yeah. I'm just going through my this thing, through the questions. Okay, should you do a routine appendicectomy and a routine cholecystectomy in advanced CA ovary?
No.
Okay, when should you remove the appendix and when should you remove the gallbladder?
In mucinous, we have to remove appendix, but gallbladder.
Mucinous also, ma'am, when we are
We discussed
seeing
this
it's
last time.
involved.
Yeah. Yeah, so we don't have to do a routine appendicectomy in all mucinous ovarian cancers because now there is enough meta-analysis to show that if appendix is grossly normal, then you don't have to remove an appendix. Okay, so appendix is normally removed during advanced ovarian cancers, generally when it is involved by the tumor or it is secondarily inflamed. And again, cholecystectomy, routine cholecystectomy is not required. However, if there is extensive right upper abdominal disease which requires omental bursectomy, lesser omentectomy, then in some case, or if the gallbladder has stones, has incidental cholelithiasis, those are the cases where you may have to do a cholecystectomy. Lymph nodes we removed. We have
one question. Supraclavicular lymph node involvement and inguinal metastasis extensive, but with limited peritoneal disease. So how should we go about this? Should we start with NACT?
Yeah. For supraclavicular, yes, it is better to start with chemotherapy first because these are stage 4 to begin with. See, the chances of finding an isolated supraclavicular lymph node in CA ovary without the involvement of the mediastinal lymph nodes is less common. Generally, you do find that if supraclavicular lymph node is involved, many times mediastinal lymph nodes are also involved. Of course, there can be chances of isolated supraclavicular lymph node involvement as well. Okay, so in case after chemotherapy there has been a good response. Patient does not have any mediastinal nodes, only supraclavicular lymph node is there. It has increased in size, but it is still there. Okay, theoretically, yes, supraclavicular fossa clearance is one possibility, but we don't have any evidence for it. We don't have any evidence to show that in a stage 4 disease, removal of supraclavicular lymph nodes actually leads to improvement in survival. In case supraclavicular lymph node is an isolated site of recurrence, okay, and rest all abdominal disease has resolved with chemotherapy in a recurrent setting. I'm talking about recurrent setting. Then there are some case series which have given radiation to the supraclavicular fossa as well.
Okay. And inguinal nodes, ma'am? Should we do a block dissection?
Inguinal. No. In an advanced CA ovary, again, see, if it is involved inguinal lymph node, what stage is it?
4B.
Yeah. So we don't do a systematic complete inguinofemoral lymph node dissection. We basically remove the enlarged lymph node. So if after 3 cycles of chemotherapy, you are taking the patient up for interval cytoreduction, if the only disease is there in the abdominal compartment and maybe the inguinal lymph node compartment, you debulk those lymph nodes, the inguinal lymph nodes.
Okay. Thank you.
Yeah. Okay. This question, I think I should have asked first. In an advanced CA ovary, where it is obviously visible on imaging that it's extensive disease and neoadjuvant chemotherapy will be required. Do you do only a cytology or do you do a biopsy as well?
Biopsy.
Biopsies.
Why? CA125 in this case is 5,800. The ratio is more than 25. Okay, we have an ovarian mass and ascitic fluid cytology is positive. Okay, so why do we need biopsy?
We have to see for the type of the tumor we can.
Correct. Right. So we have to see the correct histology of the ovarian cancer. Secondly, the tissue sample may also be required for this thing. There are many medical oncologists who start, who do the HRD scoring on the initial biopsy rather than on the resected specimen, because the resected specimen is a specimen which has been given chemotherapy first. So you should ideally go for biopsy wherever possible. Okay. Okay. Now, in secondary cytoreduction, we had discussed last time, right?
Yes, ma'am.
Yeah, we had discussed this. Okay. HIPEC, we have discussed. Kelm score, we have discussed. PARP inhibitors, bevacizumab. Yeah, okay. You can keep on reading the questions in case there are any questions.
If there is complete response of parenchymal lesion in liver post NACT, liver resections needed or not?
No. Again, we remove only the residual disease in stage 4, so we don't need parenchymal. Once the disease has resolved to chemotherapy, if you're doing an interval cytoreduction, we don't have to do hepatic resections if it has responded completely. You can also ask questions in case I'm missing out on something. I think we have discussed quite a bit. You just check the chat box in case there are any questions which we have missed, or the members can unmute themselves and ask the question directly.
And for NACT deciding which is the present score, we should say कि this is the score we are deciding to go for NACT, so Fagotti score and all.
So the Fagotti score, your Nelson's criteria, Bristow, surgical PCI, these are all tools to which have been used to help you in deciding. At the same time, we are not using Fagotti score routinely in clinical practice to decide whether this patient requires primary cytoreduction or neoadjuvant chemotherapy. Like we discussed previously, there is no PCI cutoff either. So if the performance status is good and the patient and the disease looks upfront operable, then we should go ahead with primary cytoreduction. Okay, these scores are a guide to help you in deciding for those indeterminate cases where you cannot take a call. There may be some cases which are obviously for neoadjuvant chemotherapy, and there are cases which are obvious for primary cytoreduction. And those indeterminate cases, we have staging laparoscopy to help us decide whether this patient is for primary cytoreduction or not. So the answer to your question is these are scores which have been used in clinical trials and have been validated in various studies. As of now, we are not routinely using them in our clinical practice. As long as the general condition of the patient is good and the disease is operable and amenable to complete cytoreduction based on preoperative imaging plus minus laparoscopy, then we should go ahead with primary cytoreduction.
Okay, thank you, ma'am.
Yeah.
Ma'am, in subgroup analysis of ERTC and chorus, there was like stage 4 and stage 3C with metastatic deposit more than 45 mm were benefited with NACT. So what should be our indication, especially for stage 3C with size more than 45 mm, NACT or upfront surgery?
So stage again, so this is a subgroup analysis based on a limited data where we have already discussed the criticisms of the trial that, they actually, the operative times were too less to actually say whether enough surgical effort was put in these trials. Okay, so in a stage 3, again, the answer is the same. More than the size, it is the involvement of areas like root of the mesentery or extensive porta-hepatis disease or extensive serosal and mesenteric disease, which require large small bowel resections, involvement of head of pancreas. These are the cases where we should go for neoadjuvant chemotherapy. And rest cases, if the general condition of the patient is good, then we can go ahead with primary cytoreduction and indeterminate staging laparoscopy. So subgroup analysis of a clinical trial is not necessarily a part of guideline of decision making. It is an important trial, no doubt about it, but at the same time, we are not using the same inclusion and exclusion criteria when we decide about operability in a particular case of advanced ovary.
Ma'am, for early ovarian cancer, which trial we have to quote that all patients should go for lymphadenectomy?
You tell me. There was a trial once. There was an Italian study. I think I'm forgetting the name. Basically, I'll tell you the name. I'll put it on the group. I'm forgetting the name, but basically, it said that removal of lymph nodes upstages the disease in about 20% patients. Okay, so the reason why you should do a systematic pelvic and parotid lymph node dissection is because the stage will upstage in about a quarter of the patients. Secondly, it may impact your adjuvant treatment. Okay, in a high grade serous, you are likely to give chemotherapy both in stage 1C and stage 3C. But now that we have the role of PARP inhibitors, the role of PARP inhibitors is there in advanced C ovary. We don't give PARP inhibitors in early C ovary. So stage 1 and stage 2, we only give adjuvant chemotherapy. Okay, it is only in advanced cases that PARP inhibitors are part of our armamentarium for either a gene mutation or a HRD positive tumor. So, in case you don't do a complete lymph node dissection, you are likely to miss lymph node metastasis in about a quarter of these patients. So, A, the staging would not be appropriate. B, the prognosis of the disease is affected. And third, our maintenance chemotherapy. Some might argue that, okay, if it's a high grade cancer, high grade ovarian cancer, you are likely to give only the same 6 cycles of chemotherapy in stage 1C and also in stage 3C. So what is the difference? You might as well avoid it. But the difference comes when you have to give maintenance therapy, that is PARP inhibitors. PARP inhibitors are reserved for advanced cancers, not for early. That is why. Okay.
NCCN writes that if we are giving in neoadjuvant setting bevacizumab, or we have used in early adjuvant setting bevacizumab, then only we should give in adjuvant setting. So stage 4, you said one of the disease in which we should add bevacizumab. Rest all any high risk like
optimal cytoreduction. That's what we said.
Will come to know after operation, na ma'am.
So there is no level 1 evidence for neoadjuvant bevacizumab as of now. Level 1 evidence means a randomized control trial. Okay, it may be part of NCCN guidelines. It is not a part of NCCN guidelines. It has said that it may be used. Okay, now for neoadjuvant bevacizumab, as of now we don't have any level 1 evidence. Okay, it is generally neoadjuvant setting. It is being used in cases where there is massive ascites and pleural effusion. Number 1. Number 2, the patient has been started on neoadjuvant chemotherapy, that is paclitaxel carboplatin, but there has not been optimal response and there has not been an optimum decline in ascites. Okay, so many times the medical oncologists are doing CA 125 before each cycle, and they are also assessing the ascites. If the ascites has not come down with the initial 1 or 2 cycles of chemotherapy, then in the subsequent third and fourth, sometimes they do add neoadjuvant bevacizumab. But of course, neoadjuvant bevacizumab should ideally be avoided in the last chemotherapy before your surgery, or if it has been used, then we should wait for 6 weeks or give another chemotherapy in the interim period.
Okay, ma'am.
There is a question in chat box that any PCI beyond which HIPEC is not advised.
So PCI cutoffs are not used for CA ovary. As of now, we have no evidence to say. There are some different trials. Some have used a cutoff of 18, some have used a cutoff of 24. But as of now, the recommendation is that PCI cutoffs are not really used for ovarian ovary as long as the disease is upfront operable. So HIPEC is only used in patients who achieve an optimal cytoreduction. Okay, so the same. Basically, your question should be that is there a PCI cutoff for CRS? Okay. HIPEC does not depend on your so much on your this thing on your PCI score, then it depends on your CC score. Okay, so PCI is something which is there preoperatively, okay? And we are not basing our decisions to do cytoreductions based on PCI score if the disease is upfront operable. Your HIPEC, your decision to give HIPEC or not is based on the CC score, not on the PCI score. So only if a patient has achieved a CC0 and CC1 cytoreduction do we give HIPEC.
Nowadays, for HIPEC, we are using 60 minutes or 90 minutes.
So we have sodium thiosulfate available now, okay? And the evidence, level 1 evidence we have is the OV HIPEC trial. So wherever possible, we should use 100 milligram per meter square with sodium thiosulfate.
90 minutes, ma'am?
Yeah, it is 90 minutes. 50% in first half an hour, 25% in next half an hour, and remaining 25% in the last half an hour.
Okay.
Ma'am, when should we call a palliative intent? Like whenever the case is present, like we all give chemo and we see the response, but upfront any patient came with the like symptoms of CAORI, when should we call it as a palliative intent?
See, palliative intent for an upfront patient, like I said, most patients we don't declare palliative unless they are not fit enough to even receive systemic chemotherapy. Okay. Generally, even patients who have an ECOG of 3 can receive neoadjuvant chemotherapy. In fact, that is one of the indications of giving neoadjuvant chemotherapy. However, if the patient's general condition is so poor that she cannot even withstand, the routine systemic IV chemotherapy, those are the patients that we then put on palliative care. Those are the patients which we declare with a palliative intent in upfront setting. Other than that, mostly we treat with a curative intent. So upfront setting are these poor performance status patients. Later on, then we have patients who have develop either a platinum refractory disease or are not responding to multiple lines of chemotherapy and are not able to withstand any further chemotherapy due to systemic toxicities. Those are the ones which we consider palliative. By the way, we can just briefly say what is the role of PIPEC in C ovary?
PIPEC is in
intractable ascites.
Palliative setting with intractable ascites, but the patient should have normal bowel function without any bowel obstruction. And with intractable ascites, then we can consider PIPEC, ma'am.
Yeah, so recurrent CA ovary, where patients have received 2 to 3 lines of chemotherapy in a palliative setting, where patients are developing recurrent ascites. With a palliative intent, we can give PIPEC. However, if PIPEC does show a good response, then later on these patients can be considered for definitive treatment as well. Okay. Yeah. I think at least from my side.
Ascites from unsafe, not organ of origin we are not knowing, but it's like malignant ascites of, then how you proceed?
I'm sorry, I don't follow your question.
Ma'am, patient present with malignant ascites and cytology positive, but we are not able to see any organ of origin.
Yeah.
So, in cytology, if it is showing that it is from ovarian origin, from histopath or that cell block we are taking, then how you will proceed? You will take patient for primary CRS or you will give neoadjuvant in that case?
So you are asking 2 different questions. So your question is that if a patient presents with malignant ascites, how do we and you don't know the organ of origin? Is that your question?
Yes, ma'am. Primary peritoneal cancer, it means.
So primary peritoneal cancer can present. So normally primary peritoneal cancer presents with diffuse peritoneal disease or mental disease, mesenteric disease. Unlike an ovarian cancer where there is a large ovarian mass. In primary peritoneal disease, you just find bulky adnexae because there is presence of deposits on the surface of the ovary. Okay. So you have to see the disease distribution. If the disease is primarily in the peritoneum with only bulky adnexa or just surface deposits on the surface of ovary, that is primary peritoneal CA. There is no way on IHC that you can distinguish primary peritoneal CA from CA ovary because the immunohistological profile will be the same. What is the immunohistochemical profile of CA ovary?
CK7 positive, CK20 negative, along with PAX8 and
WT1 positive, yeah. So PAX8 and WT1 is positive at least for serous cancers. Some endometrioid cancers, PAX8 can be negative as well. But most of these are CK7 positive and CK20 negative. So this immunohistological profile will be the same for primary peritoneal CA. So you cannot distinguish between primary peritoneal CA and CA ovary on the basis of IHC. You have to distinguish it on the basis of disease pattern. If on imaging there is a bulky adnexal mass and then there is peritoneal disease, it is likely that the disease originated from ovary. It is a primary ovarian cancer which has caused peritoneal spread. Okay. In a primary peritoneal disease, bulk of the disease is in peritoneum with only bulky adnexa. So they may just say the ovary is mildly bulky, it is around 5 centimeters, both ovaries, or there are surface deposits on the ovary. So it's the disease distribution which helps you in distinguishing primary peritoneal versus C ovary. But the treatment is the same, the origin is the same, distal end of the fallopian tube. So distal end of the fallopian tube is the progenitor for both serous ovarian cancers as well as primary peritoneal CS. And the management is the same. So there is no difference in management of primary peritoneal CA. It's not that if a patient has primary peritoneal CA, I am more likely to give neoadjuvant chemotherapy. Yes, the peritoneal burden may be higher in primary peritoneal CA, but the management remains the same and the exclusion criteria, as in the criteria which precludes a patient from optimal cytoreduction, is the same for ovary and primary peritoneal CA.
Okay, ma'am. That's my doubt because I was very confused how to proceed.
No, it's the same. We use the same clinical criteria. There is no difference. It's just that the peritoneal disease burden will be more in primary peritoneal CA. But just because a disease is primary peritoneal CA does not mean that you should go for, upfront neoadjuvant chemotherapy in every case. You have to see whether the disease is operable or not.
Good evening, ma'am. Ma'am, I had a question. Yes. Ma'am, if we have a patient with advanced ovary with very high disease burden on the serosa and she's presented with, because of bulky peritoneal disease, she's presented with obstruction. So what is our cutoff? Like, do we still give NACT to these patients or do we relieve her obstruction by giving some conservative measures first? Or
so, if the patient is in active obstruction, yes, we first generally try to manage the patient conservatively. And if the patient improves symptomatically, even if she is on liquid diet and she is now maintained on liquid diet, so then you can start chemotherapy. The problem with obstruction in CA ovary, unlike say CA rectum or any colonic malignancy, is that most of the time the cause of intestinal obstruction in CA ovary is diffuse serosal disease over the small bowel serosa or diffuse mesenteric disease. So many times we don't find any normal segment of small bowel to take out as a stoma. So if, for instance, a CA rectum presents with obstruction, you would do a diversion stoma first and then proceed. In ovary, on the other hand, most of the time, if the patient presents with, intestinal obstruction, most of the time the patients present with intestinal obstruction in a recurrent setting rather than an upfront setting, number one. But even if they do present in upfront setting, most of the time it is because of diffuse serosal disease or diffuse mesenteric disease. So many times it may not be possible for you to take out the stoma because there is no normal segment bowel left, or the stoma will be too high up. That will be a high output stoma, which is not conducive. So most of the times in CA ovary, we do conservative management first. Okay. And once the conservative management, the patient starts showing a response or at least is able to tolerate a liquid diet without going into features of obstruction, patient can be started on chemotherapy. But what should you avoid in these cases?
stoma.
Bevacizumab.
Bevacizumab.
Yeah. because there's higher likelihood of bowel perforation in the presence of active bowel obstruction. Yeah, I think I've completed from my end. You guys should now start asking questions. I don't have anything else except for some medical onco trials. I think you can just read them. They are most important is PARP inhibitors. They will not ask you so much specifics on uh, chemotherapy trials, but you should know the important ones.
Okay.
Yeah. Anything else in the question Q&A box? Can one of you please see? Or you can, the participants can just directly ask in case I've missed out on something. Indication of MRI as first investigation, MRI pelvis. So MRI pelvis as first investigation is used generally in early cases in complex masses in young women, where we need to know the characteristics of the mass, number one. And number two, where we are trying to have fertility sparing surgery. So in fertility sparing surgery, we need to know the nature of the mass which we are dealing with, number one. Number two, we need to know the status of the other ovary and the uterus. Only then we can do a fertility sparing surgery. So this is where MRI becomes important. Okay. Role of staging laparoscopy. Does amount of ascites matter? No. Pagoti score for PCI. Which imaging is better? Ideal, if you were to talk about clinical trials, contrast enhanced MRI with diffusion weighted imaging has been found to be superior to CT, but it has its own limitations, as in it may not be available everywhere, number one. Number two, the expertise of reading a peritoneal MRI may not be there with every radiologist, and it is more expensive. So right now, as of now, we are still considering CT, thorax, abdomen, and pelvis as our first modality of choice. Involved field peritoneectomy should be based on pre-NACT versus post-NACT disease. So this is the problem where we give neoadjuvant chemotherapy and there is clinical resolution of the disease. Many times you can find some desmoplasia, some calcification, which are telltale signs of previous involvement, but sometimes you may not. Okay, so sometimes where the patient had gross ascites and peritoneal disease pre-chemotherapy and has had a very good response after 3 cycles of chemotherapy, there might be some regions which you may not be able to tell. Some areas may have fibrosis, may have desmoplasia, may have some calcification or telltale signs of previous involvement, but other regions may not. This is the fallacy of giving neoadjuvant chemotherapy. So that is why we prefer upfront surgery. But in response to your question,